welcome to another Sagely Health webinar. I am joined, as always, with Dr. Jason Sager. Hello, Jason.
Hello, Jeremy. Hello, everyone.
So, for today's topic, March is Colorectal Cancer Awareness Month. So, we definitely wanted to cover a couple topics related to colorectal cancer. And for us, what we wanted to highlight was what are the risks of colorectal cancer and what are your options? So, I'll just introduce this a little bit. Colorectal cancer is something that really benefits from early screenings, and there's been a lot of success in kind of changing cancer rates due to early screening. There has been some recent news about rise in young people of incidence of colorectal cancer. So Jason, I'm wondering if we could kind of begin with a little bit of an overview. And I think one place to start is to say, like, what is it about the nature of colorectal cancer that makes screening such an important kind of weapon in the arsenal in the fight against it?
Yeah, absolutely. And as we've reviewed in other sessions, screening is, colorectal cancer screening is at the very top of the list amongst breast cancer and skin cancer screenings. Colon cancer screening, although somewhat more invasive in that you need a scope for it, is really, really important. And yet there are things that we don't understand about colon cancer, like why are younger and younger people getting colon cancer these days? So much so that I think, and that recently, they've changed the formal age of recommending colon cancer screening from 50 years old to 45 years old. And the really nice thing about the screening is that if they go in there, they can find things like polyps and take care of those things. And then they give you a sort of a clean bill of health, and you don't have to worry about it again for 10 years. Versus if you delay getting it, you don't know what your risk is. And so, absolutely my recommendation is always to do the screening when it is offered. And when it's offered, it means it'll be paid for by insurance. And yet for folks that are, that have higher risk, and we'll talk about what that means, I think getting it earlier and justifying it and bringing it up to discuss with your doctor that you're concerned about, let's say, having a family history where your immediate relatives, whether they be your mother or father, sisters or brothers, if folks have been diagnosed either with colon cancer or rectal cancer or at a young age, before the age of 60, these are reasons to bring it up with your doctor and say, hey, doc, I'm concerned about my risk. And can we do that colon cancer screening even earlier? Having recently done it myself, I could say that the prep regimen, because, they got to sort of clean everything out so that they can go and take a look in with the camera. The prep regimen has improved, and there's actually the old standard is called Go Lightly. And the new standard, I don't know what they call it, but they're, instead of a big sort of volume of liquid that you have to swallow, there are these little pills, and you swallow the pills plus some water, but it's pretty good. It's
That's
not
better. I have an experience with Go Lightly that I'm not going to get into, and it wasn't related to a screening. But if you could avoid that and do something else.
So again, like my friend, I mean, as a doctor, I didn't know about it either. And my friend, who's not a doctor, said, "Hey, you should go get the tablets." And it wasn't like a dream come true, but it certainly made it tolerable.
Yeah.
And they were able to tell me the timing of when it was not going to be tolerable, so that I didn't book meetings or otherwise decide I was going to try to do something like sleep or something like this. And so it definitely made it bearable for, and even better. So again, we can talk about these things because we're in a webinar. And I think it's important for people to know like the real details of what we do, because it's all important. And making sure that people can do things like get their screening and not delay it, and just do it when you can and when it's going to be paid for. But then get that clean bill of health. And now I don't have to worry about it for 10 years. And it's great. Yeah.
Yeah, that 10 years seems like a huge number to me. So let me just ask, so is that because these you said the tumors are so slow growing. Is that kind of that it
Yeah.
won't be a risk? Yeah.
Yeah. So colon cancer is a interesting cancer in that it is one of the, I believe it's one of the slowest growing. I mean, even when we see patients with metastatic disease, tends to grow more slowly than many other cancer types. That being said, it's also can be relentless, and so if you can't get it early and it's too late, then it's too late, and nothing's going to really help slow that down to stopping it. That being said, when you can catch it early, again, it takes 10 years for it to grow. So the polyp that they're removing from the colon has likely been there for many years. And, it just slowly grows over time. And that's why when they're able to clean those out, they can give you that sort of clean bill of health for maybe 5 years, depending upon what they see in the microscope,
Hmm.
or 10 years. And, when I did mine, they found a polyp, they removed it. It looked benign enough that they said, you've got 10 years to come back to us. But even if it were 5, it's still pretty far away. And so it makes you just feel so much better knowing that you've got that sort of clean bill of health from stuff that you just can't see. You can't look at and know that there's a change. So it really is nice.
So on the other side of that, and to get into our kind of main topic,
Yeah.
if you are screened and the news isn't as good, it must be really hard to understand your risks at that point. You kind of go, it's a very slow growing cancer, kind of where they are. And I know, and I'll have you speak to, I mean, I know it's much better to catch it early than it is to catch it anywhere, close to metastatic.
Yeah.
So I'd love for you to just kind of talk about like what this how the staging works and what that means, and what are the other factors that would make you how would you consider risk when it comes to being diagnosed?
Yeah. And from my perspective, it is always better to be diagnosed earlier. It's also better to be proactive about whatever stage that you're at the time of diagnosis. And so from my, and colon cancer is somewhat unique in that size matters, but what matters more is sort of that depth of invasion. And some tumors will grow sort of far and wide, but they'll kind of grow to the side. And some tumors won't grow as large, but they'll tend to grow deeper. And those are the higher risk tumors. So at the end of the day, it's the pathologist and looking at those tissue samples that they do in the biopsy through the colonoscopy or through any other biopsy that's looking at that risk and assessing it. And again, there are, just like everything else, there's sort of, 4 stages of, of risk. Stage 1 being very much local, surgically amenable. As you get into stage 2, where it can be regional, stage 3, and then stage 4 is widely metastatic. And certainly, again, for surgery matters a lot, but you also have time. Patients have time. And so getting what we call neoadjuvant therapy is one of my take home lessons for patients. Assess your options. Don't rush to surgery because the likelihood is that surgical stage is not going to change in weeks to even a month or two in between finding out what you have and deciding what to do with it. That's the first thing. And then the second thing is that when there's an opportunity, use help in making the surgery easier. We call that neoadjuvant therapy. That's therapies that are done before getting the surgery. And for patients, if you're stage 1, it doesn't matter. But if you get to stage 2 and 3, especially stage 3, those are places where that therapy ahead of time can really help to make the surgery complete, i.e., curable, as opposed to a higher risk of it not being cured or coming back. That if a few of those cells escape from the surgical field, then they're going to come back eventually. And that's something that we don't want to see happen. So that to me is one of the key principles around all of this.
I can see a difficulty there for a patient to kind of because when you say neoadjuvant therapy, oftentimes that might be radiation or that might be chemotherapy
That's right.
with the hopes of shrinking the tumor to make the surgery easier, less involved. Maybe it's, in some cancers, it's in the lymph nodes and you kind of pull it out of the lymph nodes or something like that, where it's just, like you said, making the surgery better. But I think I can see a cancer patient looking at it and go, well, I just want to get it out. I
Right.
really just I want to cut it out. I don't want the side effects that I
Yeah.
know I've heard come from radiation and chemotherapy. But I mean, but you're saying even though that may be unpleasant, that's likely going to offer
Yeah. And
benefits
and
long
again, like, like, I mean, there are plenty of reasons today to delay a little bit. And let me give you some of those because
term.
again, we want to arm our patients with things that not only help them, but unfortunately the doctor who they're seeing, who's going to be the surgeon to do the biopsy or to do the surgery, is going to say the same thing as the patient. Well, why wait? We're going to go get this out. So what you want to think about, Jeremy, is that this New England Journal of Medicine study that was done recently in rectal cancer, the same thing applies to colon cancer, which is that 10% of patients will have something called MSI high. For those patients, immunotherapy can be curative. You may not even need a colostomy or any of the things that come along with all the risks of surgery. And so again, it'll take about a month to find out if you're positive or not. But there's very little likelihood it's going to advance in that month. And yet 10% of the time, even if you don't get it, but 10% of the time, those patients are going to be cured with immunotherapy. So it's huge. And as a matter of fact, it is influencing what doctors are saying. I have a patient right now who's a stage 3 patient. And the doctor wisely, the surgeon wisely said, yes, we can go get this out. But before we do that, let's go get a circulating liquid tumor biopsy from the blood to just take a look if there's anything circulating. Let's go get send off a sample from that colonoscopy to see if there is any tumor that is MSI high. While they do that, we'll also find out about 600 other genes at least. And that can also help for the future. And so from my perspective, that's sort of take home lesson number 2. Every patient needs tumor sequencing if they're at high risk, if they're in this sort of stage 2, 3, and certainly stage 4. Um, and then finally, telling the surgeon that, hey doc, like, I hear that you say you want to do the surgery, but I'd like to wait. That sounds pretty intimidating from a patient's perspective. Instead, what we recommend is saying, hey doc, that sounds good. We can even start scheduling, get preparing for the surgery. In the meantime, could you refer me to one or two of your colleagues, a medical oncologist and a radiation oncologist? I'd like to see them to know how what they offer could help me either now or for later. And to me, with colon cancer, there is zero reason not to have those 3 doctors weigh in. And that's how you'll really find out if there's neoadjuvant, something else to do either now or later as adjuvant therapy after the surgery that can really help to improve the odds, because that's what we're all about.
So I have a question. When the colonoscopy is done and a sample is taken, they can send that to the lab for next gen sequencing. Like you said, it can tell if you have MSI high as part of the test and then any gene mutations that you have. And I bet there are probably some certain mutations that are really more prevalent in colon cancer that might be targeted more often. I think I hear KRAS a lot. And so I'm curious if someone is stage, because what I think I hear you're saying is if you're stage 2 and anything above with colorectal cancer, you're high risk.
Yeah.
Do you think that's
Yeah, I mean,
fairly
certainly stage 3 and 4, I think everyone would agree. We're a little bit more bullish than most folks are, so we would hedge on stage 2 also,
okay?
being higher risk. But certainly, I think no one would, say stage 3 and 4 is not high risk. I think everyone agrees. And stage 4 is widely metastatic. There, surgery may not even be a possibility. And colon cancer often goes to the liver. We have used other sessions to discuss how even when it does go to the liver, some of those patients are still operable and still curable with oligometastatic disease. We won't repeat that all here, but just know that it is high risk and that you should have tumor sequencing.
Yeah, I mean, I've seen the reaction of a patient who was told they were metastatic colon cancer and told, no, actually, you're still operable, like
Yeah.
with that scenario. So that's something we can. Anyone wants to email us about that, we can point you to the video where we discussed that. Great. So that's a little bit about kind of how we understand risk, and obviously, if you're high risk and borderline, we're like get the sequencing done. So can we, I guess, just then it
Yeah.
turns into like, what are your options? Kind of how do you
Yeah.
what does that test do for you? How is that maybe going to change someone's
Yeah.
treatment
And
plan?
so the third take home lesson that from my perspective is really important and critical is that patients look at clinical trials right from the get-go. If they're at high risk, get your tumor sequencing, look at clinical trials. Because there are ways of targeting these mutations, whether they be, and some of these are standard therapy. So if you have MSI high, you'll get immunotherapy with pembrolizumab because it's been approved for any patient with MSI high. And that's even beyond colon cancer. So, but from my perspective, a lot of these innovative approaches are only offered on clinical trials. And what I can share with you and show you a little bit about, and what I've done to prepare here, is just a walkthrough on on a few of the trials that exist today for patients who have that high risk but are pre-surgery. And I'm sharing my screen, and you can see that again there are folks that are working hard at immunotherapy outside of the MSI high situation, using things like cancer vaccines to help shrink the tumors ahead of time. There's diagnostics, and so again, if your doctor is resistant to getting sequencing, either with a liquid tumor biopsy, which is also called ctDNA, and here you can see a trial offering ctDNA, or here is a trial offering molecular profiling in ethnically diverse populations. And as you know, Jeremy, and we've recently discussed, Afro American patients and other patients of ethnically diverse backgrounds tend to be offered these sequencing tests less. And it's really important. So here's a trial that's actually looking to help those patients access these advanced diagnostics. And then there's some more sort of, common approaches. Something like here's a chemotherapy combination plus a molecularly targeted therapy in patients that are KRAS wild type. You mentioned the KRAS mutation. There's
Yeah.
also KRAS wild type, which is the opposite of the mutation. And this is a trial for those patients. So, and again, I'm just, highlighting, a few of these, and there's many more out there. But from my perspective, there are opportunities at each of these stages. And what I'll do while we chat a little bit more is to load up sort of what later stage patients might get in terms of clinical trials.
Yeah, well, while you're loading that up, I mean, I just make the point that you mentioned pembrolizumab being available for patients who are MSI high, regardless of cancer type, for solid tumors, and that wasn't always the case. So you are literally at a step like if you can get the sequencing done and you find yourself in that 10%, and that could drastically alter the course of your treatment. That pembrolizumab may be very, very effective for you. It might mean you don't need other types of treatments, in some cases, even including surgery.
That's
So
right.
you can kind of see what a big deal that is and how great it is that that's available. The point I make is there were patients accessing pembrolizumab 10 years ago on
Yep.
trials because it needed to be proved out. And I know, Jason, you could be looking at those trials and say, I'm looking at the data. If I have a patient that matches, I'm getting them on there because that is likely to work for them because I know what's happening there. So I just say I think there's been kind of a paradigm shift that's happened relatively quietly in clinical trials where it's gone from, oh, clinical trials will be considered as your last resort. When we've tried everything else, we'll send you down the hall to the clinical trial folks. And now, because of the targeting, because of the understanding of the genetics and the molecular attributes of tumors, that this is something where, like you said, it's just if you're high risk, then start with clinical trials.
Yeah.
I mean, I just want to
And
make that
yeah.
extremely
And
clear.
and again, the standard of care is a combination of like, 3 to 5 chemotherapy agents, right? With 5-FU and irinotecan and oxaliplatin. I mean, these are pretty high potency drugs that cause lots of side effects. And yet, what we're finding is, precision medicine matters.
Right.
And so if you have that tumor sequencing diagnostic, the genetic or genomic analysis on the tumor, you then sort of open the door. And I'm going to show you how widely that door is open. Before doing that, again, this is now first line therapy that I'm showing you. And, the fact is that, even at first line, here's HER2, right? Like HER2, that's in breast cancer. But the fact is, it's also in colon cancer. And it's in many other cancers too. So when you see HER2, either mutations, amplifications, or even high levels of protein, there's an avenue to explore there that this trial is exploring. And they're saying, look, if you have, tissue diagnostic positive for HER2, then instead of getting frontline sort of, high powered chemotherapy that's not directed, get some chemotherapy that's called paclitaxel here, but then get a HER directed antibody drug conjugate where it's targeted with a chemotherapy warhead and it's being directly administered or directed to the tumor so that there's less systemic effects. And that combination is going to go up against the standard of care. And that's really exciting to see the trials like this one. And again, we help patients no matter where they're at to find the trial centers that are closest to them. In this case, it looks like they're both at University of Colorado. That being said, again, many of these trials are distributed really widely across the U.S. And when you take a look at the whole, and here's another one that's using some anti-HER2 medicines in combination with that standard of care chemotherapy, there can be many, many, uh, trial centers. This one has, as you can see, many trial centers, including international. And so again, we're really in the business of helping patients to find how they can best utilize that information that they get from sequencing in order to dive down and access a trial that is the best one for them that will maximize their success.
Yeah, I think that the term personalized medicine gets thrown around a lot and it means a lot of different things to different people. But, when it comes to oncology and cancer treatment, standard of care by definition is not personalized. It is the averaged, arrived at standard of what has worked best. And obviously, the situations in which a standard is used does become more granular over time as new kind of drugs come to the surface and different situations and diagnostics. But when we talk about, we're going into your particular tumor, we're sending that to a lab that will come back with hundreds of genes analyzed, and we kind of, that's what we're talking about. The
Yeah.
personalization is, it is down to your tumor. These trials that you're highlighting, they have pretty complex entry criteria because they're looking for particular types of patients. So it's going to be very difficult for a patient to kind of
Yeah.
traverse this themselves.
Yeah.
It's just
And
it's a lot.
unfortunately, I wish the system were set up differently, but it just, these are not, there's very, very few motivators. Matter of fact, there's some things that restrict motivation in the system for doctors to be able to search. There's no tools for them. There's no time for doctors to help with this search. And instead, what doctors do is they go to the NCCN, which is a great group that puts together, sort of publishes the recommended standard of care, but they ignore the one sentence that's on every single one of those pages from NCCN. I know because we've looked at them. Consider a clinical trial above and beyond all of these standard options. They ignore that time after time. And so really, in order to do better, we want to be that advocate for patients. We want to be there to make sure that patients know what their options are and have the opportunity to discuss those options with their doctors. There's a big difference between when a patient goes in and asks the doctor, well, is there any clinical trials for me out there? Versus when the patient says, hey, doc, I have a list of these 3 clinical trials. Do you think they're reasonable to consider? We find the reaction to those two situations dramatically different, with the second one being much better. And so that's what we seek to do for cancer patients.
Yeah, I mean, just as long as everyone, even if they don't act on it, they understand what their options might be and where they could go to activate those options. I mean, that's what we kind of unlock for people, using our tools and working with folks. So, um, all right, what else do you want to go over?
Yeah. So I wanted just to continue to show how as we go on, in patients have, let's say they now have metastatic disease and it's come back, they may have already done the standard of care. These folks are wondering, like, what options do I have left for me? And again, there are, most patients will get FOLFOX. A good number of them will get FOLFIRI after FOLFOX. But again, at any point in time, there are trials that are available for patients. This is an interesting one that I'm going to show. It's showing on my screen here, where this is a vaccine for cancer being offered in maintenance. So this is sort of, I've gotten my standard. It hasn't progressed, so the doctors don't want to give me any more treatment, but I would like to do something. Well, this is a vaccine trial to do in that space. And so I think it's quite special. We talked about, again, targeting these genes, and here's one that's specifically against a gene called EGFR, which is also fairly common. And you start to see the numbers really increase. But what I want to show you is pretty exciting, which is exactly how much how much better you do between that 107. But now, if we add the tumor sequencing in and those results in the 107 results, I didn't highlight it, but there are 45 genes that mattered that we would look at to see, okay, well, do any of these match? But that's looking specifically at trials that are for colon cancer. There's a whole nother group of trials, thousands of trials that are for solid tumors, of which colon cancer is a group. But there's so many thousands of these that we can't begin to look at what's best for a patient unless we have that tumor sequencing. But once we do, you can see here on the screen the list of genes that matter. And there's a lot of them. Matter of fact, the New England Journal of Medicine published that you'll be able to, that 80% of the time, a patient with tumor sequencing will find a clinical trial that's out there specifically matching that tumor sequence and that gene mutation or the genetic change, the alteration. And again, you see the HER2s coming up at the top, but there are so many. There are 339 trials. There's basically every variety of these. And again, any one of these mutations will lead to a specific, for example, ALK will lead to specific trials that are looking at really targeting those mutations in a way that's unique. And I think we just had a patient come in the other day who has colorectal cancer and didn't even realize they have an ATM mutation. And to me, that patient should be on one of these trials because, again, there's a trial here that is a TKI trial that thinks that they can target this ATM mutation. And so from my perspective, there's a lot of reasons to be looking really under the surface for these patients. But, with our system that we've built, it's not hard for us to figure out what would benefit patients. And we do all the time.
Yeah, I'm struck by there's kind of two stages to this that are important to kind of highlight. We will tell patients who are high risk, go get your tumor sequencing done. If their doctor will order that from them, or they find a doctor that will, or we find them a doctor that will, when
Yes.
those results come back, you cited this 80% number, that when you get those results, 80% of them are actionable through clinical trials. I don't
Yep.
remember the exact number, maybe you do, but I know that it's only like 20 or 30%
Yeah.
that are
20%.
20. So you go to your oncologist, you say, I want to get next-gen sequencing. Maybe they kind of fight you on it, but you get it. And then you get it back and the doctor looks at it and goes, yeah, nothing here. I can't do anything with this because the only thing they're comparing against are standard therapies. And
Right.
in some cases, in the 20% of
Right.
cases, it might influence.
Yeah. Like for example, the MSI high is 10%. So that's 10% right there. And that has now gone from the investigational stage into standard. So now it's on their radar. But how
Right.
about the other 70% of things, right, that are not on their radar? that's where we
And that's the
do our
gap,
work.
and that's the gap we're filling. If you kind of
Yeah.
understand where Sagely Health kind of does some of its best work, is we've made this manageable to do these searches for patients to say you match this clinical trial, because the system puts people in different cancer centers and doesn't talk to each other in a way that benefits the patients kind of flowing where they need to flow. So we kind of operate as this triage, so we can help you with the next gen sequencing results. Because I do see that. I mean, I go on Reddit and I read stuff and I see people who are like, I got next gen sequencing. It didn't. My doctor said it didn't mean anything, and I'll message them and say like, I think you might want to look at clinical trials,
Yeah.
for that, because that's what the important step, and it's a hard step. It's hard to work
Yeah.
with clinical trials. It's a very
And
complicated.
it's almost impossible. So, and again, there are lots of folks out there who are trying to do good. We do recommend them, right? Colon Town, they're great. Cancer Commons is great. There are a lot of folks that are really trying to help patients. But from my perspective, you really need the expertise in order to get patients to the right place. So, they're all good. You could start with some of the others, but then it doesn't hurt to run it by us and see what we think. And we are able to get patients and deliver them a referral to a physician that has one of these options to provide them. And that's really the output that we seek to deliver.
Absolutely. Well, that's probably a great place to end it. I think we could talk forever on this, but
Yeah.
but yeah, I just want to remind people the website for us is sagelyhealth.com. If you have a question, if you want to get in touch with us, we are always there and available.
Thanks so much.
Excellent.
Take care.
Thank you, Dave.